Series is hosted by the Center for Bioethics at the University of Minnesota. Today, our topic is on identifying surrogate decision makers, or as our clever title is, who you're going to call when your patients can't decide for themselves. So I want to take a moment to remind those of you who are within the mHealth Fairview system that the Center for Bioethics does offer a 24/7 ethics consultation service. Anyone can request an ethics consult either through paging our service or requesting a consult in Epic. So here's the information for that. So let's introduce today's speaker. Joan Hendrickson is the senior clinical ethicist at Allina Health here in the Twin Cities. Dr. Hendrickson began her career in nursing and then earned her PhD in religious studies, focusing on ethics from the University of Iowa. And we're excited to have her today to share her expertise on this topic. And I'll be handing it over in a little bit to her. Some housekeeping information. If you have questions today or any technical difficulties during the presentation, please use the Q&A function, which is below in the Zoom kind of menu bar. This session will be recorded and recordings are available on the Center for Bioethics website. Finally, we will be reaching out for evaluations at the end of this event, either a pop-up screen on Zoom or through email, maybe in a day or two. We take your feedback very seriously and incorporate it into the planning of future sessions. So thanks ahead of time for those of you who take some time out of your day to fill out the evaluation for this event. We really appreciate it. And then finally, if you are a University of Minnesota student who is seeking IPE credit, please stay after this presentation for 15 minutes. We'll have a discussion group. If you want a certificate of attendance for all of the attendees, you can follow the link in the chat for a certificate of attendance for this presentation. And Dr. Hendrickson does not have any financial relationships to disclose for this presentation. So Dr. Hendrickson, I will hand it over to you now.
Thank you. Thank you so much for having me. It's a delight to be here. All right. So my job as clinical ethicist is really a cool job, and I'm really lucky to have it. And one of the things that we ask a lot in this sort of work is who. And so today we're going to be looking at some of the who of decision making when there's someone other than the patient who's making healthcare decisions. So the foundational values at stake here in undergirding this particular topic are honoring patient values. There are related concepts, that branch out that arise from this fundamental value. And these include autonomy of persons and capacity. And both of those have been covered in the two prior Unpacking Bioethics sessions by my colleagues, Dr.
Joan, just a minute. I just noticed your screen isn't showing for sharing. Can you share your screen?
I can try. Is it now?
Yes, now we can see it.
What's it doing?
Perfect. We're at the decision-making standards slide.
Okay. Well, here I was trying to tell you about the fundamental value of honoring the patient values, and that Jamie and my colleague Joel have both talked about things or elements, clinical ethics elements that have arisen out of this fundamental value. And so if we want to honor the patient values, we actually need to know what those are. And so the goal really is to get an understanding of, and then honor the values, how the patient would view the situation. The goal is not here to figure out a rule and then just follow the rule. So what we hope for in clinical decision-making is a shared decision, a respectful human interaction where each party contributes both their knowledge and their values. So the patient brings their life experience and what is meaningful in the situation and the way that that situation fits into the circumstances or the story of their life. And the clinician then offers the medical expertise and takes into account what's important for the patient. So this is the ideal, and this is a shared decision. When a person is unable to participate themselves in the shared decision, that doesn't mean we take the decision away. We take it into our own hands and we do whatever we think is best. In American healthcare, we've established over time and with precedent that there are acceptable ways to continue to include the patient's values in the decision. So we keep it a shared decision, but we include other people. So this is called a substituted judgment standard. You maybe have heard of this as a decision-making standard. And you've got when a person, the patient, who is now unable to participate, and a person here who has come in to stand in for the patient, represents what the patient would choose. So the person who's standing there is going to substitute the values of the patient, the preferences and choices, substitute it for their own. Okay, so the standing in person substitutes the patient's values for their own. And this substitute judgment standard still allows for shared decision-making that honors the values of the patient. You probably have heard about the decision-making standard called best interests. And personally, I believe that all decisions are made within a frame or a context of best interests, because each person in the decision-making process has a vision of what the patient's best interests are. I don't think it's usually helpful when people throw out, but it's in the patient's best interest, because that simply returns us to the same larger kind of framing problem. What is that patient's best interest? And for today, who gets to define what that is? So maybe best interest as a shared, as a decision-making standard, maybe is a good topic for another session of the series, Jamie. So maybe we can make a list here. So again, the goal is to honor the values of the patient by respecting them through shared decision-making. We need to understand what the values are. So let's look down a line of possible sources of information. So we're trying to get at those values. Now, the autonomous, capable adult patient is the ideal for, at least for us in clinical decision-making. But of course, this can even get complicated. That respecting autonomy was demonstrated by Joel, some of the complexity there in that last session of this unpacking bioethics, bedside bioethics. I'm going to skip down to guardian, because court-appointed guardians who've been given authority to make healthcare decisions, basically they jump the line. So here's another one, Jamie. Guardianship's definitely a topic for another session, but at very least, you need to know guardianship should be a last resort. It's an extreme measure, and it is nearly always unnecessary for healthcare decisions. I will make the disclaimer that we are in Minnesota. We're doing the University of Minnesota talk, and we want to keep ourselves constrained to the things that are happening in Minnesota, and we can talk a little bit more about what else is going on. So guardianship might be the most effective route for certain sorts of circumstances, but those are usually for decisions that are beyond clinical decisions, sometimes financial and other reasons, at least in Minnesota. So your local ethics consultant or places like the Elder Justice Network, they all have great resources when you need to think about this particular topic, this person. So then back to written directions. This is a way to find out what the patient's values are. Ideally, they give us information about the patient's values, what they find is important, what quality of life the person would find acceptable or unacceptable. Sometimes they even give their views on specific treatments. Don't ever put me on dialysis, that sort of thing. But really, we want to be able to get a vision into what's important to that patient. And so the written direction, either in a healthcare directive, living will, post all sorts of versions of that. Maybe we should have a session on advanced care planning, forms of advanced care planning. When we have those documents and they can be effective, we can line up the plan of care with what's possible and and then line it up with what's preferred by the patient. Hopefully, those advanced directives also name someone that the patient trusts to speak to their values and preferences. So we know that advanced directives, kind of the umbrella term, has at least 2 functions in Minnesota. You can name a power of attorney for healthcare, and you can give these sorts of directions or name your values and preferences. You can also just do a power of attorney for healthcare on a separate form. And we'd love to think that this basically takes care of the problem, because the person is named and designated by the patient themselves as someone they trust. But we know even when someone is designated, it isn't always straightforward. There's complexity that can rise here too. So maybe the person wrote it down, but the person they named now has dementia and they're not able to help. We've seen this many times. I've also seen people name all 3 of their adult children. They name them equally, and then they say, they'll work together, but it turns out that the adult children can't work together. Maybe the person who's named is unavailable, or maybe they're unwilling, or they're not as available as needed. That certainly can happen. I've also seen the person who was named, designated, say, I didn't even know I was named. I have no idea what the patient would want. I didn't ask them to do that. I didn't know this was happening. We've even seen the person who's named is sometimes a primary physician or someone that the patient trusts, but is now in a place that might have the person might feel like they have a conflict. The person who's named is maybe trying to avoid conflict with the rest of the family and are unable to take a stand or be able to function well as the named person. And certainly we have situations where the named person maybe is doing what the opposite of what we read in the directive or what the clinicians understood the patient to say. And that takes us into the how, which will be another session for another time. But each of the scenarios I'm describing really do require a careful and specific response. We can't say, here's a rule and you just need to apply it. Patients can also designate somebody outside of these really official documents and these legal documents. At least this works in Minnesota. Some other states have more strict constraints around this. And it might not work for financial decision-making, but it certainly does for us in Minnesota in healthcare. So they could designate a person to a clinic visit and they tell their provider, yeah, I would want my 3rd cousin Jenny to be my make decisions for me if I couldn't. Well, that provider with good conscience can write that in the record that this is what they were told. And for me, at least in my practice, that holds a lot of weight and does a sort of designating. People that are not able to talk, maybe I've actually seen this where there are a group of family members around the patient's bed. The patient is unable to talk, but when the palliative care provider said, who of this group do you really trust to kind of speak for you? The patient pointed to somebody. I would say that's a form of designating. So you might remember from the talk on capacity that Jamie gave, that people may have the capacity to decide something like who you trust to make decisions or who knows you really well, even if they lack capacity for more complex choices. So that reminds us to always ask the patient who they want, even if they haven't designated on a form. And then this would be another trap I would ask you to avoid. Avoid just using the emergency contact. I've seen people do that. Oh, it's in the medical record. It says emergency contact. It gives a number. In my book, that does not designate a decision maker. It might be the best person, but just because their name is there doesn't mean that the person trusted them for complex decisions. So something to keep in mind. So that's our designated alternate decision makers. But we know in that order of things that, gosh, if we don't have that, then what are we going to do? So in that case, when a patient hasn't named someone, hasn't pointed to somebody, but we need somebody. So we're going to start our first question for us. This situation is Mr. Tiari's from Texas, a young man visiting his mother in Minnesota, and he becomes ill. There's a decision that is needed. This one is a life-saving amputation. He's ventilated, sedated. He is unable to participate. His mother insists the team move ahead. His common law wife, meaning that they're not married, but by time, some states have this common law that would consider her a wife, arrives and says he would not want to live if he had to have his leg cut off. And so she refused the operation, the procedure. And they both adamantly claim that they should be the ones making decisions for him. So, Jamie, are you doing a poll? All right, so this should show up on your screen. Please join us in giving us your idea about who are you going to call in this situation? Who do we listen to? I'm just going to read off those options because they all seem plausible and people will definitely consider them to be the right answer. So you certainly could ask the mom, and if your reasoning is because she's next of kin, you could ask the significant other. Some people would do that because they'd consider her next of kin. Some people would say, well, here's the recommended treatment. We should do that, especially because it's urgent. Some people would say, let's go to the county, call them. We need some guardianship here. Some people say, well, let's just wait. We'll ask the patient himself. And some people say, oh, none of these are very compelling. What should we do? Tell me when you want to stop, Jamie.
Yeah, I'm going to end the poll now and I'll share it with you all. All right.
That's kind of cool. Does that mean everybody can see that?
Mm-hmm.
All right, so those of you who are watching and can't see it, 44% of people in our poll said we should listen to the mother because she's his next of kin. Well, of course, you might have additional reasons you would say this, but that's what we were going here, mother. 30% say the significant other because of her relationship in Texas. Some of us also want to say none. Some, let's see, 5% say attending physician, 7% say patient, and 2% say the county. So thank you. Thanks for doing that with us. And as all things in ethics, does that go away? Okay. We will have to say it depends on the circumstances, but in our case, it depends on the state. What you're going to do here depends on your state. Know the limits for your state. So this map is a rough outline of the differences between states when a patient lacks capacity for decision-making and has not named, and a shared decision is needed about life-sustaining treatments. So with those circumstances in mind, then this map says, you know, the darker states, they have some mandated rules about this. There's most likely a hierarchy, a mandated hierarchy that lists people. So they'd say, if these circumstances apply, the spouse becomes the surrogate. If there's no spouse, then the adult children. If the no adult children, then the parents, and on it goes, and so on like that. The states in white, for this purpose, don't have a list. So notice Minnesota is in white here, does not have a statute about this. So we don't have guidance, we don't have limits. There's a statement about people who are under commitment as a little exception. There's this paper by DiMartino has a much more interesting map because there are lots and lots of variations of this and it becomes complex. If you'd like to know the most up-to-date by state, the American Bar Association has a great resource for that. But what does this really mean? Well, in my mind, it means that clinicians can employ their best judgment to figure this out. So we don't have to presume that certain relationships equal knowing and honoring the patient's values. I believe there are advantages to this approach. So we can be open and flexible in learning about the patient. Maybe a neighbor has had conversations about what the person would want, and the adult child never has. Maybe a same-sex partner of many years who's not a spouse knows the patient much better than a sibling, and that sibling might not let that partner in. Maybe a young woman who's been out on her own for some years has a boyfriend who knows her values much better than her parents do, right? So we want to have the right person speak for the patient, not just the person who's in the right relationship with the patient. So in my mind, at least in Minnesota, we have the freedom to get the best person. So just remember to remind us here, the goal is to understand and honor the patient's values. And to do that, we have to understand and figure out what those values are. So how do we do that? So we're going to ask for you to think through, gosh, we don't have in Minnesota, we don't have a nice little list we just pop down. What I called freedom to make a good decision about the best person also means we have to have some criteria for that decision. So what we're going to do is ask in this poll that you offer a word or phrase for the what would make a good or effective alternate decision maker. When there are options, who do we listen to? Is it someone who shows up and yells the loudest? So give us some of your ideas about what makes a good alternate decision maker. This is kind of exciting. I can't actually see any of them yet. But they're rolling in, Jamie. This is good. Let's take just a couple more.
All right, I'm about to end the poll. Okay.
So exciting. How are we going to see them?
Oh no.
We don't see them?
I thought we would be able to see them.
We must be able to see them. You work on that. I'm going to, because I just am really confident with over 100 answers that all of these have gotten there. I am not saying that mine are right. I'm saying this is the list that I definitely use, refer to, and help advise people when they're trying to sort this out. So we are wanting to make sure that the person that we are calling on knows the patient well enough to speak to their values. We often are wanting them to know them over time so that we can have something of the trajectory of their story and know what's important to them. The person who maybe they could speak to what specific information for this circumstance might be. Oh yes, after that, motorcycle accident was in the news, this conversation about, I would never want to be on a ventilator, and can relay stories that talk about specific important circumstances. Let's see. The person that we're looking for also is able to speak this. So they have to be able to name for us some of these things and help us know how the patient would prioritize the values. And as my first little cartoon showed, they have to substitute the patient's views for their own. And it takes a lot of maturity for persons to be able to even understand what we're asking, much less do it, right? To recognize what is mine and then be able to set it aside to represent the patient, especially if they might decide differently. And they should be available and willing. And I know that in my practice, sometimes we have a great person and in the end, they're not available to us or they're not willing to help. And so that will make it harder. Okay, Jamie, did you find a solution to this problem before we moved on?
Not yet. I think we might be able to get one soon, but not quite.
Well, just let me know when, because I'm so excited to see it that we will just come circle right back around. I'm confident that these were in there, plus some really other really great ideas I would love to see. What else have you done looking for a good decision maker? And all of this can get really complicated. My clinician colleagues share their frustration with me all the time, how this takes so much time to sort it out. And of course, I think, well, that sounds like the perfect time to get some help. So this is just to remind us, you can call on your friendly ethics consultation service. Hopefully, wherever you're at, you have access to one at UM Health Fairview. This is the number you would use. And this is one of my dear friends, and this baby dressed as a Ghostbuster, just, I can hardly get enough of it. So let's imagine we have a patient who is unconscious, so can't participate, but has really important goals of care decisions to be made. So fortunately, our social work colleague has actually located a friend who has many of those characteristics we just talked about and will really do a good job representing the patient. So what needs to happen next? What are we going to do? And here we're in another poll. The ideas that have come to us are: have a physician write an order that assigns the friend as the power of attorney, have the team give some good reasons for using that person and document those reasons, have social work fill out an official power of attorney form, or have the friend contact their attorney to make sure they can do this. So let's give those options and see if we can have some answers that show up for us. Great. Thanks, everybody, for participating.
All right, I'm going to end the poll soon.
All right, so you're sharing the results. 78% of you said have the team give good reasons for using that person. Make sure to document those reasons. 10% said have the friend contact their attorney. 8% said have a social worker fill out a form. And 5% said have the physician write an order assigning the friend. Now, this is another spot where we need to at least say, you probably want to know what state you're in and what they say about it. At least in Minnesota, there's not the ability for a physician to assign someone as a POA. I've actually heard of that for other states. Sounds interesting, but that isn't going to work here. The social worker could fill out a form, but the patient is the one who has to assign their trusted power of attorney. And so if you have an unconscious patient, if the patient is not capable of doing so, then that is not going to get done. So if the patient is in this circumstance without a POA, we are not going to get one. Now, I've heard people use that language quite a bit. Well, let's just get a POA. Well, the patient can't assign it. It can't happen. I think the friend having an attorney is fine. We don't advise people. And if that's something they feel like they need to do, that's fine. But it's not necessary. Have the team give good reasons for using the person and document. This would be the ideal circumstance, in my opinion, because we need to say, you know, there was no one designated. We are in this circumstance where we want to honor the patient. We have to find out what the patient wants. In doing so, we've identified these people, and of these people, this one is the one that we think most represents the patient. And I think it's a good idea to document those reasons. I don't see it very often, but I would encourage people to do it. Jamie, you have anything for me right here?
Well, I do have the results of our last slide. So what I can do is I can read some of them off. I think there's fantastic results. Someone who's been involved in their care recently, someone who's thoughtful, informed, connected to the patient, the person who knows the patient best, who understands their values, goals, someone who's available, someone who's calm and level-headed.
Nice.
Someone who lots of knows the patients, can communicate, has a long history with the patient. This person says someone who's neutral. Interesting. This person in all caps says good under pressure.
Oh,
So
very nice. Right.
great thoughts.
Yeah, thank you. I've seen some advanced directive workbooks that have this lovely worksheet in them that give patients, as they're thinking through who would I want to designate, it gives them these little choices. That is over 18, can make a decision, will represent what I want rather than what they want. And I guess I think it would be interesting for us to talk about this idea of neutral. Does that actually get us to the patient's values? That's an interesting topic, and another one for our list, Jamie. So here's yeah, thank you. Okay, so some of us actually do see these things every day, and I will tell you that a big portion of the reasons I get consulted, so bedside ethics consultation in the hospital, is around these issues about who and these default surrogate decision-making concerns. So I was just going to describe some of the things I've seen. These are trends from my experience, but there might be 4 adult children and they are all disagreeing on the goals of care. Sometimes the family drama is leaking onto the team. Like, how are you going to reconcile that? If they're disagreeing, do you do a majority vote? Do you do whoever seems reasonable to the team? Or might just not talk to each other and they come separately? So some people find themselves wading into family drama and thinking they need to mitigate it versus keeping those clinical decisions separate. These are very challenging circumstances. I've seen 2 people appear. These are equally potentially the right surrogates. Remember, if they're default, you've got plenty of people that could be the right person. And those people describe that person as with very, very different values. And so somewhat like our first poll case, where the team gets 2 very different pictures of the patient. Maybe 2 people appear, they're equally likely, but one is easier to work with. So is that enough reason to choose that one over the other? The only person who appears can speak to the patient's values, but staff may tell me that they're unreasonable, or they can't reach them. It's hard to contact, hard to work with them. A team has been working really hard with someone. They're confident they're getting the patient's values. And then the daughter from California, the son from California flies in and wants to change everything. This one is a common thing that I have seen, and maybe some of you have too. Let's see. Oh yeah. There's fighting among people that appear. And what's interesting for me is sometimes they actually agree on the decision at hand. So they come around, we all are going to, end up in a way that distracts the team from even knowing what the patient's values are. And then we get farther away, we've got an alternate decision maker we have chosen, and that person starts saying, various people can't visit the patient, and we don't have any reason to believe the patient would say that. Maybe that person's been at doctor's visits in the past. And what are our best responses to these situations? They're complicated. And so what we're going to do is, instead of saying, hey, there's one easy approach to this, we're going to ask you to tell us which of these styles or types of problems have you experienced in your clinical practice. Of course, this no alternate decision maker can be found at all. That's when a patient lacks capacity and there's no one. And these are called unrepresented patients by some folks, or unknown patients. They're extremely vulnerable. And part of protecting them is having a process. So we might need to discern their best interests. It's something of their substitute judgment if we can find it. It's a different standard in some ways. And we're going to add this to the list, Jamie. Yeah, okay. Those unrepresented patients. So yeah, we want to hear your experience. Pick as many of these as you've experienced. Are these things you see too? Jamie and I do similar work in the clinical sphere.
Yeah, every week we get something like this.
And answers are coming in that would indicate the same for the people that are with us. Again, the responses are going to need to be customized to the problem. Great. Great.
All right, I'm going to end the poll soon, so get your answers in.
And I wish this sort of format had time for us to hear some of your stories, because I know that people in different settings in here, different states, end up with, you know, encountering the same kind of scenario and having very different kind of results. So have you shared them so everybody can see? Yeah, great. Looks like a lot of people have that that adult child coming in from California. I don't know, in Minnesota anyway, it's always California. And I suppose if you're in California, it might be from, you know, New Jersey or something where that's the scenario. Almost 70% see multiple people appearing who are describing a different picture of the patient. The values are different. Half of you have seen multiple people, but one is considerably easier to work with. Disagreement among multiple folks. Groups of equal fighting. Yeah, 40%. I'm glad to see that. I was wondering if that was just me. I feel them sucking us into family drama. And I sit back and say, but let's clarify, because we're actually all saying the same thing. All right. And almost 70% of people have experience with these unrepresented patients, patients who both lack capacity and someone to speak for them. That just is a real vexing problem, and one that's going to only increase with time. Thanks for sharing those results. Okay. We did that. All right. So I wanted just to move on to a few tips about ways that we can get in our own way, things that we do that make it harder for ourselves. So these are things that I see happen around me and with teams just way too often. So language, we can get ourselves in trouble. I've seen a lot of confusion that adds to extra complexity when people use the words POA, power of attorney, or guardian, when there's no evidence that those exist, right? So they have specific meanings, and if someone says, yep, specifically, I am the power of attorney, well, then it is worth our time to try to track that down and see that. What I've learned is that often when folks say it, they've been assigned a financial role, that they are to help with finance decisions, but not healthcare. And it matters, especially if there's conflict. I've also seen folks talk about parents as guardians, and it doesn't necessarily get us in too much trouble, but the fact is guardians are guardians, not parents. And then to be real careful about this next of kin language. I know I put it in those foils and people really go after that. And I hear my colleagues say it all the time. It is important in certain states. In Minnesota, next of kin language it's a technical legal term. It does not actually apply. It works around here in Minnesota when a person has died and the person we turn to for certain things. But when it's a healthcare decision, that is not necessarily the place we need to go. You might start there, but it does not indicate what many people think it indicates. I also find a trap we set for ourselves is once we find a decision maker, we tend to stop talking to the patient. We stop including the patient. So once we've identified somebody, it becomes easier to communicate with that person, not keep circling back to the patient. We might stop even assessing their capacity. We might like talk around them or outside the room. Oh, good, we've got somebody, not realizing that we still should involve the patient as much as possible. What I mean by rigidity, in the places we get ourselves kind of tight, clasping tightly to some certain concepts. So I've heard people say, well, how do we know that they're his wife? we don't typically, make people bring their marriage certificates to prove to us their relationships. And sometimes when we get in these situations, we tend toward rigidity or extremes. So people will say, well, their healthcare directive or whatever the thing we're talking about is, valid and legal. Well, certainly a valid and legal document increases the likelihood that we can trust the document. But from my perspective, we can use any evidence of preferences and values, and they all hold different weight depending on what they are. And if something is legal and valid, that is important in certain circumstances when certain things are contested. But we don't have to be using those sorts of phrases. And then on the flip side of that, sometimes we actually do want those defaults, those people we're trying to figure out if they're going to be effective decision makers. We want them to be able to convince us that they're the best person. So we might, I've run into people that say, I don't have to explain my reasons. And then I say, well, this person hasn't named anyone. We are responsible for sorting this out. I need to hear some of your reasons, right? So we can evaluate all those things that you were describing. And then we want to avoid imposing our values. Our ideas of how things must be can really get in the way, right? The stance we take. So for instance, you probably have heard of approaches that clinicians use to help surrogates know how to best represent the patient. So I hear clinicians say things like, if your loved one could wake up right now and see this situation, know that they had to return to it, what would they say? And that can be a very effective way of going about this, but we do tend to focus on the individual patient in our attempts to respect autonomy, right? That's one of our most important American values. But we also know that people in many communities and cultures make decisions in very different ways. So the idea of asking what an individual would want for themselves might not even make any sense. So sometimes it's not what the patient would say. Sometimes the interests of the larger group are more important, and the process used for decision-making might be completely different. So we have to be able to flex, we have to be able to accommodate that. Especially we want to find evidence that the patient adheres to that same stance, that same belief, maybe the approach and culture. But given that, then we need to be able to figure out ways to embrace and accommodate alternate decision-making processes. So we want to avoid imposing our values. Well, we want to avoid immediately going to what comes to us, what seems obvious to us, right? The idea we have in our head of the right relationship to figure out who the right person is. We need to explore the values of our patients and what it means to honor those values. That might require for us to get past our first thought. So I would suggest a few things to set yourself up for success. Remember that it might not be the person you think it is. The best person to represent the patient, if they haven't told you, may be someone other than you would look for first. When you are considering the who, explore the why. And that requires that you are eliciting values, you're asking questions to get at the patient's values. That sometimes is a skill that takes some honing. And then you're listening and putting together faithfully a story of the patient's values. Remember that we are avoiding judging the alternate decision maker's answer or the process by whether we agree with it. We don't have to agree with it. We have to know or trust that they are speaking the values of the patient. So we might want to verify that they're the patient. That might be part of our work, but it's not whether we agree with them. And then when it gets complicated or there's extra conflict or it's taking too much time away from your busy clinical practice and it's taking away from your patients, get some help. And this is one of those times you can call ethics. So just a reminder of our foundation, what we're trying to do and why we can easily get down in the details and weeds of this, but let's pull ourselves back and realize the purpose for doing it is because we in clinical care want to honor patients' values In order to do that, we have to understand them, we have to respect them. And once we have that, then we align the plan of care with those values. So that's what we're about. And this is a good start. Thank you so much for your attention.
Fantastic. Thank you so much, Joan, for this great presentation. I think this has been a fantastic introduction to the complexities of finding the right surrogate decision maker, which, as you mentioned, there are many offshoots we could take about this topic, right? Like exploring further all of these things. And so I want to do a little bit of that in the Q&A today. So if you have Q&As or questions, I should say, we'll have the answers. If you have questions, please put them in the chat. We'll have about 10 minutes to talk about some of these more nuanced questions. So the first question we have in the chat is, someone says, what are your recommendations for when the person who is named is unwilling to follow the documented desires of the patient?
I can't see anyone anymore.
Uh-oh.
What's on here?
I can see you. I'm still here.
Oh, good. I'm glad you're still here. Yeah, I think that's definitely a place that we find ourselves, and a place that advocates of advanced directives can get frustrated with. Why do we even fill these out if they're not going to listen to them? What I want to always do is approach that this is an evolving story, and that people have written their preferences down or given you some sort of document, is what the question was about, at a moment in time in their story. People try to anticipate what some of these circumstances might be, but I have never seen an advanced directive that is absolutely precisely interpreted for the circumstances that they're in. And so there will always be the work of interpretation of what they were saying, what they meant in the current circumstances. And so what we hope for is an alternate decision maker of whatever sort, being as true to what they understand the patient having lived their life like, but also what they would have meant in their advanced directive. When I come across conflicts of those things, I am looking for that alternate decision maker to try to make that story make sense. Explanatory story. How would you describe to me why you're saying this about the patient when I read the advanced directive to say this? Help me connect those dots. Mm-hmm. And then that might lead to some openness for further conversation.
We had a case a couple of weeks ago where a patient's son was saying, it doesn't matter what the patient said, once she loses capacity, I get to decide whatever happens. And so she had said something like, I want to be a DNR. And he said, that doesn't matter because I get to decide. What do you think about that situation? Like, what should we do in something like that?
Yeah, that's a great question and a hard scenario, and one that is not all that uncommon. I usually recruit my legal colleagues, and we look at that to say, around this case, like whether they're named a certain way in a document. One of the responsibilities of an alternate decision maker is to honor what is known about the patient's values. And so if you can show with some certainty that this patient said this, and this is what they held, and this was the most current understanding of their values, that person's responsibility, their job, is not to say, well, now it's mine, I get to do whatever I want, but to say, my job is to represent the patient. And in this scenario, it would say, even if I don't want it, that patient said she wanted to be DNR.
Mm-hmm. Yeah, it can be tricky.
Very tricky.
Yeah, but that's
the
great.
person who's now in front of you, who's telling you, I get to do it, is the person you have to deal with. And mm-hmm. and that I think emotionally and time-wise can just be consuming for clinicians. And it's a hard thing to navigate, a lot of relational and communicative work.
Mm-hmm. Mm-hmm. Okay, let's move on to another question. You mentioned that, states that don't have legal guidelines for who the decision maker is kind of gives a sense of freedom. This attendee said, wouldn't absence of a list also possibly mean no freedom? I think in Wisconsin, absence of a list means if a patient hasn't named someone, a guardian must be named in order to make medical decisions.
Yeah, it's good to know your state and your limits of your state. And so, yes, there are complexities in Wisconsin that we are aware of because we see Wisconsin patients. And there are certain sorts of decisions that need a guardianship. And that has been, decided at a state level. And so, yes, in that case, the lack of hierarchy has created a scenario that then creates this really complex legal process that can take a long time and can really harm patients.
Can you clarify a little bit more about why you think that sometimes not having these guidelines or state regulations can be freeing?
Well, some of my colleagues that are doing this work in other states find, 98% of the time with our patients, whoever shows up is probably their, official next of kin or their spouse. Like most of the time it goes by those hierarchies anyway. But the times it doesn't are usually the times where it matters.
Mm-hmm.
And so my colleagues in other states who have those hierarchies will find themselves being frustrated with, oh, well, the spouse is alive, available, but they've been separated and estranged for 5 years. And yet officially we have to use this person who might be in direct contrast with a friend or neighbor who for us would be the most likely to know the patient well. And so what my colleagues in other states are finding is that it forces them down a path or makes that path a lot harder when it's named in that way.
Another sort of clarification about state boundaries. If a patient is being treated in your state, but they're from another state, which state regulation should you follow?
That's a great question and one that comes up a lot. And I think is exemplified by the common law wife from Texas. Well, you're in Minnesota. We can only understand and support the boundaries and limits we have. So Minnesota, what we do have are agreements across states that we will try insofar as we can to honor legal valid documents from other states. But if they're from Oregon and they're requesting, physician aid in dying, things that are not appropriate for our state, just because they came from there doesn't mean that we do it. So always say in our home, we follow our house rules.
That's great. Here's a question from the chat. This person says, I've seen cases where a religious leader shows up early in the care and looms large in the patient's discussions with family, and eventually starts convincing the patient to limit access to family. How would you address something like this?
Looms large. I think, Jamie, you probably have experienced that too. And it could even be, within families, a certain personality comes and changes the dynamic very powerfully. I think when there's a religious leader or you've added some sense of authority that that we believe the patient actually respects and honors, it can make it very complicated. That they are course of the care can be very distressing to the care team, of course, because they are seeing that maybe that isn't how we started here. But I would come back to the idea that if we have evidence that this is representing the values of the patient, and we don't have a good evidence to the contrary, a lot of things can fit within what is ethically justifiable. It takes some savvy, some communicative relational savvy to maybe sort out who has what views, and just because it's loudest, that doesn't necessarily mean it best represents the patient. And if we find out that the quiet voice who's almost deferring but doesn't want to is the best person, then sometimes we need to come and step forward and maybe support the person to hold a certain line, or even sometimes take on more of that responsibility in those scenarios. Very complicated situation you've described.
Yeah, I find too that sometimes it can be difficult as or an ethicist or perhaps like a care provider to allow patients to make decisions that we might disagree with, right? So if we find that a patient comes in as saying this, and then either a religious leader or even a family member comes in and says, no, I don't want you to do this, you have to do this, and they change their mind, that can lead to a tricky situation because which one's the authentic value and goal of that patient? And in reality, patients are allowed to make decisions based off family members and community values, right? Like it's absolutely like, how rigid would it be if we said, no, you cannot make a decision influenced by others, right? That would be inappropriate almost.
Yeah, yeah. Very recently, we had a situation where the patient was clear on what he wanted, and he had two strongly religiously motivated family members who convinced him to change his mind. And that made our staff very uncomfortable, but people can change their mind. And people often do, because one of the values they hold is love for their family, or I wouldn't want to hurt my family. I will do things or sacrifice other values or prioritize my loved ones over my own. And sometimes that's the value that wins the day.
Yeah. So in light of that, I think there's a great question in the chat, which says, what should we do when the patient's most recent choices or expressions of their goals and values contradict with a previously documented choice or goal?
Yeah, that's a great question. And again, sadly, right, it all depends. It depends on the context. It depends on the relationships. So if a patient has a document and since then has been giving us information, but then loses capacity, there is a tension. But if we have good information and we've done a good job keeping track of the information, we can make a strong argument for holding what they said most recently. If you don't have that, or it's really flimsy, or somebody said, oh yeah, they said that, but we don't have enough to go on, people are going to want you to go all the way back to the thing that was written. And that certainly holds weight.
Fantastic. All right, I think we have time for maybe one more question. I'm scrolling through.
I'm glad there are lots of good questions, and that will give us more ideas for our big list of next topics.
I'm curious what you think about this, Joan. So in your first case, going along with the wife's recommendation not to amputate, it feels very unsettling. So what would you do before going along with her decision? How would you kind of parse out how to make sense of these two different values coming from two different sources of surrogates?
Right. So if you actually have two different pictures of the patient and an inability to get kind of the patient to tell us, I certainly go looking for corroborating information. So who else in the family? What other relationships would support this view of that patient? Do we have a primary care provider who has seen the patient and has experienced something along the same line? Also, it will trickle down eventually to the point of what will give us the best chance of more options. So if you have two equally possible representations of a patient's values, which set will give us more options for moving forward? Well, saving the patient's life sometimes allows us that flexibility, and people will go for that in order to have more time, more conversation. Those depend a lot on the story in front of you. And I guess we didn't actually answer that question, that we had to put the mother and this significant other in conversation with each other and work toward a consensus sort of decision. We couldn't just say, hey, here's the rule, we're going to listen to you. And of course, that can only cause more antagonism in some families. So in
that specific case, right, I think often it can be pretty, maybe we default to going to finding just one person, but oftentimes it's appropriate, in fact, more appropriate to involve all the surrogates and to actually go through the work, even though it's more effort, right? To go through the work of finding consensus, like you said, and that perhaps we're, and what do you think about something like compromise? Like if we're not finding consensus, like is compromise something that's equally as good to shoot for?
think integrity preserving compromise, things people can live with and not feel too compromised that they can't live with themselves, is certainly an option. Though we might wish it, none of this is set in stone, and it all depends on context and relationship and the patient's values.
Well, thank you so much, Joan, for joining us. This has been a fantastic presentation, a fantastic discussion. Just a reminder to attendees, we will have a recording of this available on the website. There are two things that I want to promote. One, Dr. Henderson is teaching a course for the Center for Bioethics next semester. So that is available for upper level undergrads, graduate students, and non-degree seeking students. So if you're interested in that course, please check that out. And we have another, an ethics grand round session coming up that will be fantastic. It's on the consequences of overturning Roe versus Wade with Dr. Mary Faith Marshall and Lynn Paltrow, which are two fantastic experts in the field. So be on the lookout for that. It's on November 18th.